To the next session.
Yes, sir.
Okay, sir. Thank you all. Welcome to the Gomoti. That is the Master Echocardiologist case-based discussion. So I will request the Professor Dr. Shahana Jamal to conduct this session. Can you hear me?
Yes, sir. Can everybody hearing me?
Yes.
Am I audible? Yes.
Yes.
Thank you and welcome everybody to BD Echo 2020, and our today's session is Master Echocardiologist case-based discussion. Name of the session demonstrate that it is the session of the masters who do not need any introduction. And today's session chairpersons are our chairpersons in these sessions are Professor Mir Jamaluddin, Professor Syed Ali Ahsan, Professor Abdul Wadud Chowdhury, Professor Abdul Kader Akando, Professor Harisul Haque, Professor Dipankar Chandranag, Professor M.A. Bashar, Professor S.M. Siddiqur Rahman, Professor STM Abu Azam, and Professor Biren and panelists are Professor S.M. Mustafa Zaman, Professor Taufikur Rahman, Professor Masud Jia Chowdhury, Dr. Mizanur Rahman Shapon, and Dr. Mahbubur Rahman, Dr. Dhiman Banik, Dr. Nur Alam, Dr. Muhammad Ataul Haque, and Dr. M. Tamzeed Ahmed. We have 8 presentation. Each presentation has 10 minutes time, 8 minutes for the presentation and 2 minutes for the discussion. But we have 7 presenters. As this is the master series presentation, all presenter here are the legendary presenter. First, our first presenter is Dr. K. Sivakumar sir, who is don't need any introduction. He is a legendary echocardiographer. Is a pediatric cardiologist working as a Madras Medical Mission, and he has experience, skilled in every aspect of echocardiography, and he has done a lots of complicated and challenging intervention in pediatric echocardiography. I'm asking and I am requesting Dr. K. Sivakumar sir to presenting his cases.
Thank you very much, madam. Are you able to see my slide, madam?
Yes.
Okay. So actually there are 2 presentations that are given for me. So I'm going to discuss 2 cases one after another. It is going to be something like a dissection of the heart on echocardiography. Let us look at all the clinical features as well, and step by step let us come to a diagnosis. A 12-day-old newborn baby presents with severe respiratory distress for 1 week duration. Outside echocardiography in an apical 4-chamber showed a large VSD, and there was severe pulmonary hypertension. When we saw the child has marked tachypnea, respiratory distress, chest recessions, increased sweating, heart failure, but no clinically detectable cyanosis. The face was suggestive of Dye-George syndrome, 22q11 deletion mutation. Femorals are felt. The lower limb saturation is 87%. Upper limb saturation is 95%. So that means there is a differential cyanosis. There is a systolic murmur in the left sternal border with an S3 gallop, and liver is enlarged. Chest X-ray shows a large heart. So now step by step let us analyze this patient. Subxified short axis view, superior vena cava is coming to right atrium. This is the left atrium, intact atrial septum. Behind the superior vena cava is the right pulmonary artery, and the right pulmonary artery is having a continuous flow. There is on the same subxified view, there is a perimembranous VSD, left ventricle, right ventricle, a large perimembranous VSD below the aortic valve, and this is the septal tricuspid leaflet. So close to the septal tricuspid leaflet. Now, if we look at the color flow, it is a left-right shunt, laminar flow, no pressure gradient between LV and RV. So, there is severe pulmonary hypertension. RV pressures is same as LV pressures. This is the descending thoracic aorta on subsified view. You can appreciate that there is a continuous sort of flow. There is flow in diastole also. You do a spectral Doppler and you find that there is a spillover in diastole also. So the information until now, there is a large perimembranous VSD with predominant left-right flow, no IV gradient, so severe PAH, hyperkinetic PAH. Abdominal aorta shows continuous flow even in diastole, and there is a continuous color flow in the right pulmonary artery. Now we move from subsified to apical fourth chamber. There are two good-sized atria and ventricles, right-left atria and right-left ventricles. There is a large perimembranous ventricular septal defect below the aorta, and this is the apical fourth, the parasternal long axis. The aortic valve, if you carefully see, it's an eccentric opening. So aortic valve is not opening centrally, it is eccentrically opening, which means it is possibility of some bicuspid aortic valve. But the color flow is not turbulent. So it is an unobstructed aortic valve. You can see the large perimembranous VSD. And this is the main pulmonary artery, which is unobstructed. Pulmonary artery is larger than the aorta. Now going to short axis view, main pulmonary artery continues as left pulmonary artery, right is not seen. Now if we go back to our original image, in the subsified view, we identified a continuous flow in the right pulmonary artery. Now here, right pulmonary artery is not continuous with the main pulmonary artery. Right is missing here. So from the main, this is the ductal view. The main pulmonary artery is continuing as the ductus into the descending thoracic aorta. So the descending aorta is fed by the ductus arteriosus. You will remember that when we looked at the abdominal flow, it was a continuous low velocity Doppler. So this is the Doppler flow across the ductus arteriosus. So now if you look at the suprasternal view, the aortic arch is branching into right innominate artery and left carotid artery. And right innominate artery is now giving a vertical PDA. The PDA is going towards the right pulmonary artery. So the right pulmonary artery, which was disconnected from the main pulmonary artery, is now connected through this narrowed ductus from the right innominate artery. Aortic arch, we are able to see the two branches, right innominate artery and left carotid artery, and after that there is no further arch. The descending thoracic aorta is not connected to the ascending aorta. The arch is missing between the left carotid artery and the descending aorta. And this is the continuous flow in the right pulmonary artery. The last branch of the arch, which is the left subclavian artery, is actually arising in continuation with the descending thoracic aorta. So there is a gap between the left carotid and left subclavian. So arch is missing between left carotid and left subclavian. So a cartoon of the echo, superior and inferior vena cava were draining normally. Posterior to the superior vena cava, we found the right pulmonary artery, but the right pulmonary artery was having a continuous flow. There was a large perimembranous VSD with a left-right flow. The RV was giving rise to a dilated main pulmonary artery. LV was giving off an aorta with a bicuspid aortic valve. There was no bicuspid aortic valve narrowing. The main pulmonary artery continued only as left pulmonary artery and without a right pulmonary artery. The main pulmonary artery gave the ductus, which was slightly smaller, and so the descending thoracic aorta was having a low velocity continuous flow. Subclavian was also from the descending thoracic aorta. Aortic arch gave only these two branches, right innominate and left carotid. Arch was missing between the two. So the final diagnosis is large perimembranous VSD, severe hyperkinetic PAH with left-right flow, bicuspid aortic valve with no aortic stenosis or no aortic regurgitation, interruption of the aortic arch type B, duct-dependent systemic circulation, isolation of right pulmonary artery, and duct-dependent right lung circulation. So it's a child also had DiGeorge syndrome. So it is basically the entire cardiac anatomy, you are able to step by step proceed from each and every views, starting from the identification of the veins to atria, to AV valves, to ventricles, to semilunar valves, to great arteries. You are able to get a complete diagnosis. So, if you look at the essence of pediatric cardiology, it is a dissection of the cardiac anatomy by a systematic echocardiography. We divide the heart into segments and analyze each segments. Starting from veins, atria, ventricle, great arteries, their connection, and the final echocardiographic diagnosis is actually a virtual anatomical dissection. Every part we are piecemeal dissecting and we are trying to get the diagnosis. I have got a second talk, so I'll just complete it and then if there is any question, I will take it. The second talk, a 5-day-old baby, a similar sort of dissection. A 5-day-old baby, cyanosis from day 1 of life. Here the femoral pulses are normal. There is a uniform cyanosis of 85%. The last patient I told there was a differential cyanosis. This is a uniform cyanosis of 85%. No dysmorphism, no syndromes, mild cardiomegaly, closely split second heart sound with a loud P2, short systolic murmur. I will show standard views, very standard views. Apical 4-chamber. Left ventricle is giving off aorta and pulmonary artery. There is a large subaortic VSD here. Aorta is overriding around 50%. There is a right atrium, tricuspid valve, right ventricle, and there is a left ventricle. Left ventricle is looking slightly larger. Color flow from the same apical view, not much of obstruction in either the aorta or the pulmonary artery. The mild turbulence in the pulmonary artery is just an indicator that there is a higher QP. So unobstructed pulmonary valve and aortic valve both arising from the left ventricle. 3D echocardiography from the same view. This is the left ventricle, the papillary muscles. This is the aorta, this is the pulmonary artery. And what is shown in the arrow is the perimembranous large subaortic ventricular septal defect where the aorta is also overriding. So 50% of the aorta is committed to the RV and 50% of the aorta is committed to the LV. Now comes the question. Is it transposition because LV is giving the pulmonary artery and RV is giving the aorta? So now what we need to see will be aortomitral continuity. So this is aorta, this is mitral valve, aortomitral fibrous continuity is present. So this left ventricle is actually giving this aorta. But the subaortic VSD, there is a lot of aortic override that RV is also committed to this aorta. If we sweep to the left, you look at the pulmonary artery. Now the VSD has disappeared. So this is the pulmonary artery with pulmonary valve. And pulmonary valve is also in fibrous continuity with the mitral valve. So there is no subpulmonary conus, there is no subaortic conus. So now if you look at the color flow, the right ventricle blood is predominantly going into the aorta. Part of left ventricle blood also goes into the aorta. And there is an aortomitral fibrous continuity. Now if you look at the LV to pulmonary artery flow, the left ventricle is flowing entirely to the pulmonary artery and pulmonary mitral continuity. So there is selectively more of LV blood going into the PA. And previous view we saw RV blood going into aorta. So it is like a transposition like physiology. This is the subsified view. So again you can see the mitral valve here. Mitral aortic fibrous continuity. RV pumping the blood towards this subaortic VSD into the aorta. So RV blood goes into the aorta. But LV is connected to aorta. And so LA, LV, aorta, RV, aorta. This is LV to pulmonary artery on a subsified view. The VSD has disappeared and the LV is completely committed to the pulmonary artery. Color flow on subsified, RV blood is going into the aorta, causing unfavorable transposition like streaming. and LV blood is primarily going into the pulmonary artery. In terms of relationship of the great arteries, this is the normal thymus, aorta, superior vena cava, main pulmonary artery, normally related great arteries. And so this is the left and anterior pulmonary artery, right and posterior aorta, with the coronaries arising from the aorta. So what do we see? A dissection. Atrioventricular concordance. LV gives both the great arteries. Large subaortic VSD with aortic override of 50%. LV blood is streaming to the pulmonary artery. RV blood flows through the VSD into the aorta. So there is a transposition-like streaming of unsaturated blood going into the aorta and saturated blood going into the pulmonary artery. Normally related great artery. Normal aortomitral fibrous continuity. And pulmonary valve is also continuous with the mitral valve. Pulmonary mitral fibrous continuity. So the diagnosis is double outlet left ventricle. So double outlet left ventricle is a condition where left ventricle gives both aorta and pulmonary artery. Aorta, because there is a subaortic VSD with the override, RV blood to some extent goes into the aorta, but LV blood predominantly goes into the pulmonary artery. There is complete absence of conus. There is no subaortic conus, there is no subpulmonary conus. Clinical presentation is like a transposition with a normally related great artery. So this is a 3D view of the CT scan, left ventricle, aorta, pulmonary artery, the left ventricle's papillary muscles, and this is double outlet left ventricle. So basically, in these two examples, what I wanted to convey is again the same thing. Heart can be dissected very nicely in the living status by systematic echocardiography with detailed assessment of each and every segments and performing an analysis, and we will be able to come to a correct diagnosis in almost majority of complex congenital heart diseases by very careful visualization of all the structures and correlating clinically with the clinical findings. Thank you very much.
Thank you, sir, for your excellent presentation. Now it's 4 minutes for question answer.
Actually, I want to remark something.
Yes, sir.
Sivakumar, sir, this is Jaman.
Yes, sir. I am happy to see you.
Very excellent presentation. It's so minute and detailed description. There is no scope to interfere or to say anything suggestive of this. But you have said the right thing. For diagnosis of the congenital heart diseases, one should have very good and sound knowledge about the segmental analysis, and one should have very good knowledge of the congenital anatomy defect. So it's a very good, very fantastic demonstration, particularly the double outlet left ventricle. I have seen, honestly, I have seen this is the first case that I have seen the aortomitral and aortopulmonary continuity in the same case. Thank you for your good demonstration.
Thank you, sir. I miss staying with you personally in Dhaka. In fact, every time I come to Heart Foundation, I spend a lot of time with you, and yes, I miss the.
Yes, I like congenital.
Lots of saris in Dhaka, so I'm missing.
Yes, sir. Ma'am, we are missing you, ma'am. Vijayalakshmi, ma'am, we are missing you. I'm Nilufar, ma'am.
I think we are time.
Can I
time,
just
so
I can say one thing with Dr. Sivakumar's presentation, Dr. Rakesh Gupta here.
Sir, it's a pleasure to see and hear you, sir. I enjoyed your potpourri of cases.
Thank you very much. Dr. Shiva is an excellent dissector of the heart in pediatric neonatal population to make a correct diagnosis. But the most important part of these pediatric or neonatal importance is you have to spend time with these kids. And we have seen adult cardiologists working like a postal stamp department, one patient stamp, another patient lying on the bed in another 2 minutes time. So this is a hard work which you have to devote over a period of time. That is the most important thing. I must congratulate Dr. Sivakumar. I'm an ardent fan of yours, Shiva. I can tell you that.
Thank you, sir. The same.
Right, sir. Right.
I
Thank
share
you,
the
sir.
same feelings with you.
Thank you very much.
Wonderful man.
Same feelings.
Nice to see you.
Thank you.
Same feelings. Dr. Rakesh. Same.
Thank you, sir.
Excellent case demonstration, Shiva.
Thank you, sir.
See you live, inshallah.
So we can switch to the next speaker.
Now we are going to Dr. Rakesh Gupta sir. He is an excellent teacher, dedicated echocardiographer, and is very respected and well-known person in our cardiologist and echocardiographic society. And he is the chief cardiac consultant in JRPO Heart Care Center, and he is the chief coordinator and course director of JROP echocardiographic course. It is my privilege to welcome him as a presenter now. Dr. Rakesh Gupta sir. Sir.
We cannot hear you.
Sir, we cannot hear you.
Please unmute yourself.
Thank you very much for kind introduction. And after listening to Dr. Sivakumar, I'm just going to show a small presentation which I recorded. If you can look at my screen on 11/11/2020. History of this patient is she is 26-year-old female. She is neither hypertensive nor diabetic. She is non-smoker, non-alcoholic, non-obese, non-hypothyroidism. CAD, there's no history of coronary disease. ECG is normal. NAD was the chest was normal, no snoring. Echogenicity was fair. The only indication for presentation was tachycardia. Let's look at these echo films now with a small history of this. Let's look at the echo films. This is first echo film. If you look at this echo film, you can jolly well say, well, we have a significant amount of mitral regurgitation. We have got some amount of aortic regurgitation. And this LA and LV, both of them are bigger if we measure by 36.2 millimeter per meter square area and LV 39 and 25 with a normal wall thickness. So these were the two things which were dilated LA, dilated LV, and significant of MR as well as AR. This is a static film for mitral valve and aortic valve, and try to concentrate what exactly this static film is telling you in one go. Obviously LA measurement, LV measurement, and then finally again a color Doppler. We went on to measure the aortic valve VTI of aortic regurgitations, vena contracta, not VTI, vena contracta. It comes out to 0.43, 0.45, 0.47, classifying into somewhere moderate severity of aortic regurgitation. Short axis, pulmonic flow normal. Then let's look at the LV function now. And very critically, if you look at the LV function, LV looks to be reasonably fine. 4-chamber, 2-chamber, and finally the 3-chamber V. And apart from LV, there's something very important seen in this particular V. 4-chamber, concentrate, that concentration needs a really a good concentration. Significant amount mitral regurgitation. We looked at a vena contracta, thou overestimated. It comes out to be almost 0.85. I was trying to look at a vena contracta in Plaque's view. Where's the right method? It was coming at 0.6, 0.65, 66, but I was not able to get a perfect. But the most important thing, it is thou overestimated. It comes out to be 0.85. And then we looked at the velocity of mitral flow, that's 2.59. Then A velocity is 2.27. And if you look at the gradient, gradients was 23.54 and 14.58. Important gradients. Then I went on to do a PISA radius for this patient. As we do a pizza radius for this patient, this comes out to be a little down, 0.21, and the pizza radius after multiple calculation was 0.65, and the MR velocity was 4.56 meters per second. Aortic flow velocity, and we could see signals of AR, we could see signals of aortic flow. Tricuspid, normal, but significant amount of pulmonary arterial hypertension in the sense of 3.84, 59 millimeters of mercury. My question at this moment is, we can open up a mic, we can say, are we yes or no? My question at this moment is, the diagnosis, all of us agree, rheumatic heart disease? No difference in diagnosis, because we could see doming, we could see thickening of. How about MS? Patient is having a mitral stenosis or not?
No.
Mitral regurgitation or not? AS or not? AR or not? If I go and dissect one by one, we looked at a mitral stenosis with a gradient of 23.54 and 14.58. Does it belong to severe mitral stenosis? If yes, why? If not, why? And in this circumstances, second is mitral regurgitation. Do we say the mitral regurgitation is significantly present or not? Aortic stenosis, of course, is not there, but we have significant of aortic regurgitation. So we have a mixed lesion of MS, MR, AS or AR. If I exclude AS, then we have an AR. Now, what is the dominant lesion out of this? If I've got a patient like this, should I continue with the medical management or should I go for surgery? So I have to decide what is a dominant lesion for this. And for showing a dominant lesion, I'll have to go further a couple of slides and then I'll come back to subsequent effects. Now, does AR affect the assessment of mitral valve severity in MS, MR, AS, AR? Let's look at this. MS with aortic regurgitations, 60% of those with rheumatic mitral stenosis will also have AR. In approximately 10% of them, AR would be severe. We were moderately severe. In remaining, it will be mild. Now, but the question is, the presence of AR will shorten the pressure half time and in turn overestimate the mitral valve area by pressure half times. So if I go back to my slide, what was my pressure half time? My pressure half time was it is seen in the subsequent slides. The pressure half time was, I'll come back to that again. And second thing is the eccentric jet, if it hits on an AML, which is doing in our case, a reverse can happen. PHT will be falsely increased, resulting to underestimation of mitral valve area. So both the things of AR reflects in mitral stenosis. And what do we do when we have this AR with mitral lesions? This pressure half time could be overestimated, could be underestimating. Then we have to rely on planimetry. And when we went on to look at a planimetry for this patient, the planimetry area was, here is a planimetry area, 2.81. Now the gradients were very high. They were suggestive of mitral stenosis, but planimetry in presence of AR or otherwise will give a fairly good idea. We don't only do a planimetry by 2 dimensions echocardiography, we do a planimetry by 3 dimensions echocardiography also. Here is a cursor line which just cuts on the tip of mitral valve leaflet. The area is 2.92. By 2 dimensions, we were getting 2.8. By 3 dimensions, we are getting 2.92. So one thing is out, mitral stenosis. Let's get down to next, mitral regurgitation. If you happen to look at this mitral regurgitations, especially in this especially in 3 dimensions view, look carefully what exactly is happening in this 3 dimensions view. There's a flail AML which is seen over here. And once I showed you a 2 dimensions windows for functions, not only this, there's a absolutely sometimes there's non-coaptation of the mitral valve leaflets. So we are moving towards severity of mitral regurgitations. And if I have to look at the severity of mitral regurgitation, the best method which is available as on today is a PISA method, and which I did in this patient. This was where the calculation was 2.3 pi r square into velocity of aliasing into PISA radius. What comes out to be almost 0.3 is a effective regurgitation orifice area, which is severe is 0.3. So in turn to say that this patient which has been having a moderate aortic regurgitations, there is no significant LV hypertrophy, LV-LA they are dilated with evidence of flail AML that is seen specifically. Now look at this view, which is a frozen view. There is absolutely non-cooperation of mitral valves. And with this kind of a lesion, and which is categorically seen with 3 dimensions echo, where we can see a flail leaflet in transthoracic echo itself, with the mitral valve area is 2.92. It could be under or overestimated by pressure half time, but we have to rely on 3 dimensions or 2 dimensions mitral valve area, which is normal, and MR is contributing to all the gradients, and we have to think of this patient. Now we can also look at an LA appendage for this patient via oblique image. Same thing, 3 dimensions, transthoracic mitral valve area. IVC normal, and this is the final report for this patient. If you happen to look at the final reports, dilated LA, dilated LV, normal wall thickness, ejection fraction is almost, when we calculated, it came out to be almost 55%, which is low. When LV-LA is dilated, it has to be overactive. It has to be hyperdynamic. The LV function has started falling down automatically. And we talk of a then normal RVRA, gradients are almost 64 millimeters of mercury. The most important crucial point is dilated LA, dilated LV, what we've seen over here. Then thickened mitral leaflet, restricted cusp motion, flail AML, non-cooptation of mitral leaflet with increased flow velocity and gradient suggestive of progressive mitral stenosis. Mitral valve area 2.07 by planimetry, pressure half time, which is over or under, and we were supposed to underestimate because the jet was falling down in AML. Then planimetry 2.81 in 2 dimensions, 3D 2.92, severe mitral regurgitation both by vena contracta as well as by PISA method, patient in normal sinus system and tachycardia. Thickened calcified aortic valve leaflet with restriction of cusp motion with high normal flow velocity with moderate AR with ARVC of 0.43. This is what the sum up of this case patient is. This patient was referred to us for evaluation whether this lady needs a valve or a medical management. Second issue now. Let's come down to practical. She's 26. She's unmarried. Another problem. And on top of that, she is, by culture and by religion, she's a Muslim lady. So what do we do with this patient now? If you look at all the parameters, whatever we talked about, she is a one candidate who should go to metallic valve. But she has to be at the child's. So what do we do? That's a big question. If I have to give a question and the patient is ready, we have to give her a bioprosthetic valve. And bioprosthetic, we have to take care of her religion also. So that's what all I wanted to talk about this particular patient, which was referred to us only 3 days back for their final opinion. Thank you very much for your patience here. I'm open for questions.
Thank you, sir, for your beautiful and exceptional presentation. Now it is open for question answer. Please.
Thank you, Dr. Rakesh sir, for your nice demonstration of this case. I think I would be mistaken by, driven by the peak velocity of the mitral valve and pressure half time. So this is a very learning point for me. Thank you, sir.
Thank you very much. Thank you. Thank you very much.
Actually, it needs the interpretation of all the variables, like hemodynamic variables, chamber dimensions, that will make you conclude to the severity of the lesion. Obviously, it's a severe lesion and need an intervention. Thank you, sir, for your elaborate discussion and display of all the parameters, hemodynamic parameters. We are in time constraints, so I will request Dr. Shahana to switch to the next speaker.
I like to welcome our next speaker, Dr. Shomi Srivastavsar, who is another excellent teacher and who can do very easily a complicated case and convert it into a simpler demonstration. He is working as the head of non-invasive cardiology at Ascot Fortis, Delhi. I'm welcoming Dr. Shomi Srivastavsar.
You must say Samir Khan. He's not master, he's a Khan.
Welcome.
Samir is not there, I believe.
Sir,
We are not finding.
so are you present, sir? Shamir, sir?
What you do, you should take up a next presenter. I'll put
Right.
Samir and
We go for the
meanwhile
next
I'll ask-
presentation, and when Shamir comes, you can request him to present.
And go
Next
to the
presenter.
Next presenter, Dr. Satish Govind, who is he is also Chief of Non-Invasive Cardiology in Narayan Institute of Cardiac Sciences. I'm welcoming Dr. Satish Govind sir to present his case.
A very good evening to all of you. Many thanks to Bangladesh Echo for this kind invitation. Wish them more success and more progress. So this particular case, I've named it a stress with a twist. This is about a 40-year-old female, a healthcare worker who was on coronavirus duty. And this was in the early days when the lockdown had just started. So there was a lot of uncertainty and a lot of fear. And these people were doing almost about 12 hours work. She also gave history of diabetes and hypothyroid. So on a particular day, she had this headache and body ache, for which she took treatment. She was given IV diclofenac and immediately developed anaphylactic shock. She was treated at that center and then referred to us for further management. So she was basically in shock at that time, sinus rhythm, and she was stabilized. And this is the ECG, which shows T inversions, very minimal ST depression in some leads. The QTC was around 460 borderline. The echo showed very classic where we have this the movement of the basal segments, which showed significant contraction, but there was for some reason the video is not coming. I apologize for that. So there was the mid and apical segments were almost akinetic to hypokinetic, while the basal segments were hypercontractile. And at this point, there was finding where you can see that the apex was showing severe decrease in the contractility, the strain, while the basal segments show good or acceptable contraction here. And the mitral inflow showed diastolic dysfunction of the restrictive time. The investigations were done, and at this point, the troponin was increased, sugars were increased, and the TSH also, mild dyslipidemia, and importantly, the COVID was negative. So she was, at this point, diagnosed to have stress cardiomyopathy, and with a trigger of emotional and physical stress, the physical stress being the anaphylactic shock. Now, when you look at stress cardiomyopathy, you have these various presentations. So this top one, where you have the classic typical apical ballooning. So this is the most commonest. And then you have the mid-ventricular, and then you have the basal or the reverse Takotsubo. Then you have the biventricular also to a lesser extent. Very rare, very difficult to diagnose is this focal dysfunction Boston, and there have been some reports of even global Takotsubo, which has been quoted in literature. The criteria for Takotsubo has varied. So initially there was Mayo Clinic, which had a very simple sort of criteria, looking at wall motion and absence of coronary disease and the ECG changes. Over a period of time, the European Society, the Heart Failure Association came up with a more elaborate criteria where they've included a lot of and more detailed explanations for each of these manifestations. They've also added the ProBNP here, and this also can be done and should be included as far as their criteria is concerned. And then you have, I think this is by far the most reliable one, and the registry itself, the Inter-Takotsubo registry. And here they have made a mention of significant coronary disease not being a contradiction in the Takotsubo. And these patients also have no evidence of infectious myocarditis. So this additional sort of focus it makes it slightly different from the previous criteria. Now, the scoring for the Takotsubo, again, looking at various points here. So the female, the emotional trigger, and then the physical trigger are the ones which carry the higher points. Then you have the ECG, then you have these various disorders. So a score of somewhere around more than 50 should be good enough, but 70 would be quite sort of definitive. And anything less than that, one needs to consider acute coronary syndrome. So this is just a score, this is just a guide with a specificity, and one can sort of work around this. So in view of increased enzymes in this particular patient, there were risk factors, and she also gave history of previous atypical chest discomfort. There were ECG changes, especially the ST depression, which was there. So CAG was considered. So in the CAG, it showed a proximal to mid-LAD critical, very severe lesion at this point. Now, what really surprised was that this, again, I apologize for the video, some problems there. The wall motions totally disappeared. So this actually showed that there was a total absence of the mid and apical contraction, and this was even before any sort of intervention was done. She was just on medical management. So within 2-3 days, she had a normal LV. So now the diagnosis had one more point. So apart from stress cardiomyopathy due to the anaphylaxis, and she also had coronary disease. So she went through the intervention, and then it was a successful one. She did pretty well. And at discharge, again, she did pretty good. The LV was almost normal, and her GLS came to almost around 19. She was stable, discharged, and doing well on follow-up. So this is just to highlight how Takotsubo can present in different ways. So there have been case reports which have been mentioned in the literature. So here you have an antibiotic, and even sometimes the contrast itself can be a problem, and sometimes using excess adrenaline during some procedures where adrenaline is required, that itself can trigger the Takotsubo. So one has to be careful with these scenarios. That apart from the medications, there have been reports of associated Takotsubo and coronary disease. So here is a presentation about a case report of 2 cases actually. So both had Takotsubo with coronary disease. So in one, the scenario, the way it has been narrated is that the coronary syndrome itself acted as a trigger. So it can actually cause Takotsubo. While in the other patient, the story is that this coronary disease is more of a bystander. So you can have different ways of presentation. So it can actually act as a trigger, or it can be a bystander. So the association of CAD with Takotsubo has to be kept in mind. And this is from circulation, small numbers, just about 23. But again, look at the high sort of percentage of patients with atherosclerosis, almost 70%. So it's important that we keep this in mind, that Takotsubo doesn't necessarily have to be without coronary disease. They can present with coronary disease. So the key message from this patient is that Takotsubo can present in myriad ways, and sometimes it can result in management dilemmas. And the message here is that it is always good that if a patient does have anaphylactic shock, it's useful if echo is done. One can always pick up the presence of the wall motion abnormality suggestive of Takotsubo. So it would always be good in such scenarios that we consider echo. And we can also look at the coronary disease. So there's a strong association which has been shown. So this can be bystander or a trigger. And in such cases where the stenosis is quite significant, it can be there can be clinical intervention in terms of CAG, PCI, as we saw in our patient and who did pretty well. Thank you.
Amma. Acha, for ekটু পর দাও। Ruma.
Thank you, sir, for your brilliant presentation. It's a very good information that Takotsubo can be associated with coronary disease. So due to time constraint, I want to request the Dr. Shahana to switch to the next speaker. Dr. Shahana?
Yes, sir. I now welcome Dr. Aniruddha, who is working as a consultant cardiologist in Apollo Hospital, Kolkata. Dr. Aniruddha.
Am I audible?
Yes.
Yes, sir.
Thank you, organizer, for inviting me this case. And I am this time missing the hospitality of yours. Of course, we are hoping that we'll be, in the next time, we'll be able to make it.
Right.
Here is a unique case of there is a two small RV and two LV apical aneurysmal-like structures. They are looking absolutely same, but structurally, morphologically, and physiologically, these are different. How it happens is the story of a 25. First case is my story of a 25 years old lady, and you can see that 25 years old lady, where you can see there is an LV is almost normal, except the apex is a little dilated, and there is a hypoplastic RV. But the important thing to see, certain thing, in the second case you can see, the same thing almost like that. Is a LV, 9-year-old boy, and there is an hypoplastic RV. So these are looking like absolutely same, but there is all the difference of this case. So first I concentrate on the case number 1. This is a 25-year-old lady. Okay, there is a history of occasional episode of dizziness and irregular heartbeat, the presence of mild cyanosis, systolic murmur in the precordium with the normal ECG. The first is we're going to go to the subcostal view. We can see the atrial septal defect with predominantly right to left shunt. Now is the inferior vena cava is dilated, non-collapsing with a spontaneous echo contrast. When you look at the mitral parasternal long axis view, you can find out the mitral valve with a moderate to severe mitral regurgitation, and the mitral valve is also thickened, and probably there is a prolapse of the posterior mitral doublet. But what you see is very important in this slide is that the right ventricular outflow tract is absolutely normal with normal outflow tract flow. Now look at this view is very carefully. This is a left ventricle. There is a thickened mitral doublet. There is some prolapse of the mitral doublet of the posterior mitral doublet, or also the anterior one. But if you look the LV very carefully, these are totally smooth walled left ventricle. So what is left here is the right ventricle, which is hypoplastic and is totally filled with the thrombus. Now, couple of slides you can find out the there is a separation of the thrombus from the RV wall. And if you look more carefully, this is the totally smooth wall of the LV, which is from the another view, from the two chambers view. Now, look at the RV inflow. Tricuspid valve formation is absolutely normal, and the annulus is absolutely normal for that age, and we calculated the Z score, that is absolutely normal. And thrombus is almost filling up the RV body. Now we can find out there is an adequate flow through the tricuspid valve to maintain the RV cardiac output. And this is the flow across the tricuspid valve. And of course, this is the view for the murmur. You can see the mitral regurgitation. You can see moderate to severe mitral regurgitation is present. And this is the flow across the tricuspid valve. And so to summarize this case is a hypoplastic RV ventricle with normal wall thickness and is not apex forming. So the normal tricuspid and pulmonary valve morphology and the physiology. Left ventricle relatively dilated with normal function. Atrial septal depicted with bidirectional sun, but predominantly right to left. A large thrombus in the RV and moderate to severe mitral regurgitation due to mitral valve prolapse. Now, even though the right ventricle is hypoplastic, it is maintained the sufficient pulmonary blood flow. And despite the small size of the RV in our patient, it was still able to generate adequate ejection fraction, which may explain the lack of symptoms till 25 years of age. Unfortunately, we failed to perform the MRI in this patient, but in a similar patient, I'll show you the MRI. This is the same thing you can find at the LV with some bulging at the apex, and RV is not apex forming. It's a hypoplastic RV with enlarged RA. So MRI finding is revealed as a non-apex forming right ventricle with a small size of trabecular portion. No MRI evidence of arrhythmogenic right ventricular dysplasia, right ventricular outproduct aneurysm, or myocardial scarring was noted. So this is an isolated right ventricular hypoplasia. These are called IRVH. The RV is considered hypoplastic if the distance from the valve annulus to the RV apex is less than half the distance from the mitral valve annulus to the LV apex, which is present in our case. RV hypoplasia in adults is often secondary to disruption in the blood supply to the right ventricular myocardium due to coronary artery anomaly, which is obviously not present in our case. RVH is also associated in some Owen's anomaly, but most important characteristic that IVRH is described in the absence of those conditions when the right ventricular cavity size is reduced and the ventricular wall thickness is normal. And most cases in literature of IV is associated with an ASD or a PFO. So in a case series that summarizes 15 cases of IRVH, all the curve associated with either an ASD PFO, all presented with the cyanosis. Most of these cases were found to have a right atrial enlargement and a right to left shunt through the intratracheal defect. 7 out of 15 cases were reported to be familial. IRVH is found to 1-day-old male and 34-year-old father with no significant finding on genetic counseling. And the rare variant of IRVH in a set of asymptomatic twins is also reported. However, IRVH with a large thrombus in the RV is not reported in the literature. But what should be the management in this case? Better to wait and watch if not significant symptoms. Because why? Surgical report of IRVH was reported in a case series of 4 patients involving closure of the ASD and right atrium to pulmonary artery conduit. Post-operative course was complicated by arrhythmias and sinus flow dysfunction in all the patients. RA2P connection or Fontan repair should only be restricted to patients with severe hypoplasia. Now come to the case number 2. This is a 9-year-old boy presented with a cyanosis and claving, shortness of breath, class 3 with a mild hepatomegaly. You can see the claving and of course the cyanosis you can find out, and the chest X-ray ECG is almost normal. But the similar finding in the subcostal view with ASD with right to left shunt. And same finding is that RV outflow tract is normal with normal flow in the RV outflow. But when you get to the 4th chamber view, here is the thing that to be looked at. Here you can see this is a smooth wall LV, but come to this area is the trabecular myocardium. Actually, this is a portion of the right ventricle. There was a large apical VSD which has been restricted by the moderator band of the RV and totally shutting the VSD and cutting the part of the RV below the trabecular portion, above the trabecular portion to inlet portion to a smaller size right ventricle. So this is actually the part of the right ventricle and this is the left ventricle and this is totally cut off. So if you see very carefully, this is a totally trabecular muscles. And now concentrate on the tricuspid valve and the RV. There is no clot in the RV here. And you can see the tricuspid valve is well formed, and you can find out the very good flow across the tricuspid valve to maintaining this cardiac output of the RV. So same thing like that. So it's basically is a large apical ventricular septal defect with separation of the right ventricular apex from the remaining RV by excessive trabeculation, thereby eliminating any left to right shunt across the ventricular septal defect. It's a rare and distinct type of morphology and physiology. Physiologically, there is no apparent hemodynamic disturbance. But why there is a cyanosis and clubbing? See, the right ventricle, the basal cavity size and RV inflow are normal, and tricuspid annual diameter 16 millimeter with a Z score of minus 1.86 in 9-year-old boy is well enough. Right ventricular outflow duct is normal aorta and the main pulmonary artery, confluent and good side branch pulmonary artery. Apical segment distal to the moderator vein integrated to the left ventricle, and the resultant apical dilatation of the left ventricle. Is the large apical muscular defect of ventricular septum closed by the moderator vein. As a region, functional hypoplastic right ventricular cavity with the increased RV and diastolic pressure, there is increased RAP, right to left shunt across the large AST. There are three important cases reported. First reported case in 2007, where there is a spontaneous restriction of an apical VSD localized within the right ventricle in the region of prominent apical trabeculae. So there is a third case, is a large non-restrictive apical ventricular septal curtailed by the anomalous right ventricular muscle band, and they have described in the variant of double chambered right ventricle, and it has been reported from the Calcutta in the published in the Indian Heart Journal. This is a story of again 6-year-old boy, asymptomatic boy, the large apical non-restrictive ventricular septal defect. The same thing, and you can see that I can find out this picture from the net and almost looking like us, but there is a difference here. Here is VSD is still persisting. There is a restrictive VSD is still persisting. So you can find out in the angios also. But the second case is interesting. This is a 48-year-old male who is complaining of unspecific symptoms such as sweating, palpitation, and atypical chest pain. And the data at the local hospital include TMT, which was found to be inconclusive. There is a cardiac radiation, normal coronary, and the cardiac LV angio showed suspicion of the left ventricular LV aneurysm that for surgical therapy. Patient already lost his employment as an engine driver and was in serious fear of sudden rupture of the presumed aneurysm. And you can see the large LV aneurysm you can in echocardiography. And this looks there, it is still picture, still looks like the same picture as in our cases. There is a suspicion that the VSD was there and is being closed. So here is again the large apical ventricular septal defect, and there is a separation of the right ventricular apex from the remaining RV by excessive trabeculation, and thereby eliminating any of the left rectus and across the defect. And if you do the MRI, is a very interesting finding. You can find the morphology of the LV is colored in red, then the morphology of the RV is colored in blue, and the morphological RV but functional LV, what is there, is in green. And this is the white area is the blood pool between the red and the blue resembling the VSD, which was present there. And this is the same MRI. So these type of apical VSD constitute a rare and distinct type of morphology and physiology, and has to be considered in patients with suspected LV aneurysm. When you suspect the apical aneurysm there, absence of coronary artery disease and lack of any heart murmur. Our patient is symptomatic with class 3 DOE, cyanose, and failed to gain weight. But what can you do for the child? Thank you.
Thank you, sir, for your beautiful presentation. Now it is question answer session. It's open for all for question and answer. If there is no question, then we can, if you are short of time, we can go for the next cases.
Yes, okay. I think you should switch to the next.
Now it is the time for our professor and professor of Emeritus, who is a living legend in our subcontinent, Professor I.V. Vijayalakshmi Madam, who is the pioneer in the pediatric echocardiography, and she has skill and experience in every aspect of congenital and pediatric cardiology, both non-invasive and invasive. It is my privilege to welcome IB Vijayalakshmi Madam for presenting his case. Madam. Madam, unmute please. Madam, we can't hear. Ma'am, unmute yourself. Madam, unmute yourself.
Yes, yes.
Minimize this screen.
Yeah.
Yes.
Okay. Good evening, everybody. Sorry for the delay. This is an eye-opener case. Many of you might have seen this, but must have missed it. So I want to emphasize how we have to look at it. This is a 14-year-old girl who was diagnosed as primary pulmonary hypertension earlier by the CT angio. So they had thoroughly evaluated and made it as PPH and put her on the treatment. However, she came with the sudden onset of shortness of breath just 4 days ago, and since one day she was very bad and she came in a gasping state. We had to intubate, put her on ventilator, saturation was 85%, and she was in a cardiogenic shock, and emergency echo was done at the bedside. And here you can see that IVC and the hepatic veins are dilated, and there is a spontaneous echo contrast. So apart from the sec in the IVC, you can see that there is a massive pleural effusion. So that indicates that she is in a congestive cardiac failure. Now, what must be the cause for the congestive cardiac failure? When the apical fourth chamber was done, you can see that there is a large thrombus attached to the RA, and there is a RA-RV dilatation. So RA-RV dilatation is known to occur in primary pulmonary hypertension, but why the RA thrombus? And then we went ahead, and when we measured the size of the thrombus, it was 2 by 3 centimeters, a very large thrombus, and there was a pericardial effusion too. So when we went to the RV inflow portion, then we could see that there was a dilated coronary sinus, the Thebesian valve was prominent, and then there was a membrane across the right atrium. So this right atrium across the RA, it cannot be seen in the apical fourth chamber. It is seen only in the RV inflow view, and this membrane is right across. It is not the eustachian valve, it is not the Thebesian valve, it is almost crossing across the right atrium, and this is in the past was called as a cor triatrium dexter, and now it is called as divided right atrium with the pericardial effusion. So here you can see that this is the coronary sinus, the Thebesian valve, and then from there it is going across. This is the pericardial effusion all round because the patient is in cardiogenic shock. In most of the cases, this anomaly was recorded in the necropsy, in the autopsy cases only. And compared to the cor triatrium sinister, this is extremely rare, and it constitutes less than 0.1% compared to the sinister. So here you can see that the patient has got an obstructive membrane which has caused the stasis, and that has caused the thrombus formation, and multiple thromboembolic phenomena has caused the pulmonary hypertension. So basically, it is not the primary pulmonary hypertension, it is a pulmonary hypertension because of the repeated thromboembolic phenomena. So when we did the contrast echo, you can see that typically, here you can see that the contrast is going into the distal chamber and into the RV, and very little portion is coming through the fenestration as a puff of contrast into the proximal chamber. That means if the whole membrane is so comprehensive that hardly there is any fenestration and any flow across that. So apart from this, when we injected the contrast in the upper limb, that entered the distal chamber. Normally, it is said that both the SVC and IVC drain in the proximal chamber, and the distal chamber will have the RA appendage. But here, our one vein was draining into the proximal chamber, other one was in the distal chamber. So here, when we injected the contrast in the upper limb, it came into the proximal chamber. You can see that the concentration of contrast is more, and through the fenestration, it went into the distal chamber and the RV. So this shows that IVC and SVC were draining into two chambers separately, and that's how the contrast is concentrated in the proximal chamber when we inject in the IVC. And here you can make out that the patient has no contrast is going into either LA or LV. That means there is no ASD, there is no PFO. So one has to distinguish between the Thebesian valve. Here you can see that this is the dilated coronary sinus, and the Thebesian valve is guarding this. So this Thebesian valve will not extend up to the lateral border of the RA. So that means the whatever membrane you have is not just the Thebesian valve, it is extending up to that. So that case was not a Thebesian valve. And apart from that, you can see that there is a Chiari network also. So the Chiari network will be moving like this. You can see that the Chiari network is moving like this. This is the IVC, and that is the Eustachian valve. So Eustachian valve is guarding the IVC, Thebesian valve is guarding the coronary sinus, but this membrane that we have in the divided right atrium, it goes across. So normally it regresses between the 15-day gestation, and here when it doesn't regress, it continues to have like a membrane across. Now it is very important to make out whether this membrane across the right atrium is fenestrated or not fenestrated. If it is fenestrated and there is no obstruction to the flow, the child will be completely normal, and the child will it will be detected either accidentally on the table while doing the surgery for something else, or it will be in the autopsy. But now the 4D echo has come. With the 4D echo, you can make out whether fenestration is there or not. In this 4D echo, you can see from the RV side as well as from the RA side. So there you can make out whether the fenestration is present or not. Now you can see that there is a fenestration in this patient, and as a result, this another patient, this is not the one which I presented earlier. So this patient was asymptomatic, required nothing. So this is the Eustachian valve, which is a giant one, and that is guarding the IVC. So there is no obstruction to the flow, no thrombus. So you don't have to mistake this for the divided right atrium. So this was a 2-month-old child, came with the respiratory distress, had a TAPVC, and having seen the both cor triatrium sinister and dexter in my earlier cases, now I have seen more than 22 cases of cor triatrium dexter. So I immediately recognized the membrane in the left atrium as well as the membrane in the right atrium. So now, when it is the cor triatrium, the membrane is in the left atrium, we call it as cor triatrium sinister. When the membrane is in the RA, we call it as cor triatrium dexter. But suppose when the membrane is in both, it is not cor triatrium. Should we call it as cor quadriatrium? And then this picture I sent it to Bob Anderson, and Bob Anderson said that better not call it as a cor triatrium dexter or sinister, better to call it as a divided right atrium, divided left atrium. So these are the two legends who have given the legendary names. This is Bob Anderson, who calls it as a divided right atrium, divided left atrium, and this is Richard Van Praagh, with whom I worked, and he calls it as cor triatrium dexter and sinister, which we were taught as students 30 years back. So this is an eye-opener. Any patient coming with a pulmonary hypertension, look for the thromboembolism, look for the thrombus. Remember the Vishwa's triad. There must be stasis of blood or endothelial damage, or there must be hypercoagulability. In absence of hypercoagulability and in absence of any endothelial damage, if there are thrombus and thromboembolic phenomena is occurring, look for the stasis caused by the membrane which is not fenestrated. Thank you very much for your kind and patient hearing. Thank you.
Please unmute yourself.
Yeah. Yes, sir.
Thank you, ma'am, for your excellent, brilliant, and eye-opening presentation. For the time constraint, I'm not taking any question, and I'm going through for next presentation. Next presentation is Dr. Debika Chatterjee, who is acting as a chief cardiac consultant in non-invasive cardiology in Rabindranath Tagore International Institute of Cardiac Science. Please, Dr. Debika, madam.
Am I audible? Hello?
Yes, you are audible, ma'am.
Okay. Thanks, Ravana, and thanks once again for inviting me, and good evening, everybody. I am going to present a case of adult onset cyanosis. My patient is a 47 years old female, normotensive, non-diabetic, presented to us with insidious progressive shortness of breath on exertion for 7 years. She had 2 episodes of hemoptysis in last 1 year. On examination, we got pan-digital cyanosis with involvement of both upper limb and lower limb, and which was noticed for last 3 years. And she had grade 2 clubbing for last 3 years. Her oxygen saturation at room temperature was 88%, and she had polycythemia. ECG was normal. X-ray also showed mild cardiomegaly. And when I did the echocardiography, in parasternal long axis, I could see enlarged LA. LV was normal. RV also looked normal. Normal aortic and the mitral valve, there was no MR or ER. In parasternal short axis, I could see pulmonary artery a bit dilated, but there was no abnormality in the flow. There was no evidence of patent ductus arteriosus also. Aortic valve has 3 cusps. I did the 4-chamber where I could see both the atria were enlarged, but the ventricles were normal in size, a good LV systolic function as well as RV systolic function with TAPSE of 2.5 centimeter. She had a trivial mitral regurgitation and some tricuspid valve regurgitation also. And the tear gradient was 56 millimeter of mercury. Her IVC was normal in size, but it was showing sluggish respiratory variation. So she had a pH in the moderate range. We did transesophageal echo also to rule out any possibility of any shunt anywhere. There was no ASD, no PFO we could see. There was no BSD also. And all the pulmonary veins were draining normally. Now, where do we stand now? If we sum up the findings, she presented with dyspnea, hypoxemia, cyanosis, clubbing, unexplained hemoptysis, polycythemia, oxygen saturation was 88%. So all these findings were suggestive of right to left shunt. But in echo, using both transthoracic and transesophageal, we could not get any evidence. Now, what should we do? Is there any other test, any other scope of echo for looking right to left shunt? Yes, there is. It is the saline contrast echocardiography, as madam also has shown. Though it is known since 1968, but often we forget to use this simple, inexpensive test to rule out right to left shunt. Here we have 5 to 10 ml of saline is mixed with 1 ml of air, and also we draw a small amount of patient's blood and we agitate it in 2 syringes connected through a 3-way stopcock, and then we inject in the peripheral vein rapidly. As we inject, simultaneously we do the echo recording also of multiple cardiac cycles, at least 14 to 15 cycles. Now, normally, as we inject the agitated saline, it goes to the RA first, then to the RV, and then pulmonary artery. And then from pulmonary artery, it goes to the lung. But these bubbles, these air bubbles, cannot cross the pulmonary barrier because the size of the bubbles are bigger than the pulmonary capillaries. So bubbles remain on the right side, they never appear on the left side, and we call it negative contrast echo, and we come to a conclusion that there is no right to left shunt. But if the bubbles appear on the left side of the heart, it indicates that the patient is having right to left shunt. Now let us see what happened in our patient. We injected the saline, it's filling the right side, and then it is coming to the left side. As you can see, 1, 2, 3, 4, and the 5 cardiac cycles, it appears on the left side of the heart. So it indicates that patient is having right to left shunt. Now, is it possible to come to a conclusion at which level the shunt is? Yes. With the time of appearance of the bubbles on the left side, we can locate the right to left shunt. If it appears within 1 cardiac cycle, it indicates that there is an intracardiac shunt. But if it appears within 3 to 8 cardiac cycles, it indicates that there is an intrapulmonary shunt. So bubbles traveled from RA to RV, then pulmonary artery, and then shunt occurred from the pulmonary artery to the pulmonary vein. And so the bubbles appeared in within 3 to 8 cardiac cycles. Let us count here. It appeared at around 4 to 5 cardiac cycles. And furthermore, if the bubbles appear in the LV after 4 to 5 cardiac cycles, it is consistent with an intrapulmonary shunt, that is the pulmonary LV that occurs in pulmonary arteriovenous malformation. And depending on the number of bubbles appearing on the left side, we can grade the degree of shunt also. If there is no bubble, then it's grade 0. Obviously, it's grade 0. When there is less than 20 bubbles on the left side, it is called grade 1. And if it is more than 20 bubbles, but incomplete opacification of the LV and LA, it's called grade 2. And with grade 3, there will be complete intense opacification of the left side. Let us have a look at our patient. The bubbles are almost completely opacifying the left side of the heart. So our patient is in grade 3, and these are the patients where we need to go for further investigation like CT pulmonary angio to rule out the pulmonary arteriovenous malformation. So we did a pulmonary CT angiogram where pulmonary arteriovenous malformation was diagnosed. As you can see, this anomalous connection between the pulmonary artery and the pulmonary vein, which was later closed by a coil. So pulmonary arteriovenous malformations are abnormal vascular connections between a pulmonary artery and the pulmonary vein, causing intrapulmonary right to left shunt. And the symptoms typically appear in 4th to 6th decade of life with unexplained dyspnea, hypoxemia, hemoptysis, even stroke or brain abscess. And in these cases, we should not forget about this established, simple, inexpensive, yet surprisingly effective saline contrast study to diagnose it and to confirm the diagnosis of right to left shunt with a very high sensitivity and low risk, and we can even identify the severity of the shunt. Thank you.
Thank you, Madam, for your excellent presentation.
Thanks.
Okay, it's an excellent session. So due to time constraint, I don't know, we should proceed to the next session. All the speakers were very good and excellent. Very fluent speaking, and we gathered knowledge in different aspects. Now, is there any Professor M. Jalaluddin, sir? Are you present here? Can you hear me, sir? So with a lot of thanks to all presenters, so we want to conclude this session and we want to switch over to the next session. Thank you all.
Am I audible?
Yes.
Yes, Shaila, yes.
Yes.